Welcome to the Nutrition Hero Podcast with Dr. Brad Watts, making heroes in functional medicine and clinical nutrition. Now, here's Dr. Watts.
What's up, Nutrition Heroes? This is Dr. Brad Watts, and you are listening to another podcast episode of Nutrition Hero, where we're not just celebrating the art and we're not just celebrating the science of functional medicine, clinical nutrition. We are celebrating them both, gosh darn it. And what's awesome is today's going to be no different. I have some hormone information for you today. We're going to go through a review of male and female hormone pathways. We're going to talk about some of the common pitfalls that you're going to find in clinical practice in both situations, and hopefully give you some information, some perspective that you're going to be able to apply ASAP. So I'm excited about that. Side note, I'm headed to the FCA conference in Orlando, Florida, coming up next week. If you're going to be there, you come find me. I'm going to be there with the biogenetics crew next week. So you come find me at the biogenetics booth, and we can talk mechanisms. We can nerd out over some of that stuff if you like, or we can talk a little bit about the art of functional medicine as well. I will be there. Hopefully you are there. It's going to be humongous from what I understand. I've never been. This is my first conference, FCA conference, so I am pretty excited. So we'll see how it goes. Should be nice. Hopefully the air conditioning should be nice and cold being in Orlando in August, whoever's idea that was. So anyway, I'll be at the biogenetics booth. Stop by and let's chat. That would be awesome to meet you. So, all right, today we're going to talk about male hormones first and foremost. One of the things I love about hormones is everybody has them. Kind of like if you're a traditional chiropractic doctor and you're treating spinal conditions or subluxations, if somebody's got a spine, they can benefit from chiropractic care. You know that. Well, if you're a functional medicine provider, what's awesome, everybody has hormones. And hormones are in the wheelhouse of functional medicine. In the wheelhouse. Like, when you understand hormones like the back of your hand, and you can manipulate hormones, but also you can speak to them with your patients, you are creating a space for yourself in the functional medicine, in the functional medicine practice or in the functional medicine niche, that is a space of knowledge that not a lot of doctors have. So if you look at it from a traditional perspective right now in modern medicine, and I say modern in quotations, right? Modern medicine, what's happening is every doctor that you're going to come across in your city is looking at hormones from a replacement model. Even if they say they practice functional medicine, most of them don't understand the concept of functional medicine. When they have supplements in their clinic, or they're like going to tell you to go get your Centrum multivitamin from Walmart, they think they're practicing functional medicine when in fact they're still practicing allopathic medicine with nutrition. And because you're a functional medicine provider, because you're a nutrition hero, because you are coming at it from a different perspective, we want to make sure you identify that, you draw a line in the sand for your patients, and you say, whoa. That doctor does not practice functional medicine. That doctor practices from a medical perspective, an allopathic perspective. So if you want to talk about how to demonstrate to your patients that you practice functional medicine, it's in your language. It's in your language. Remember, language reflects culture. I think I might have talked about that back in one of the first few episodes, but language reflects culture. And you can't even get to action without going through language first. And so language is the root of culture, and that's one of the reasons why functional medicine is becoming more mainstream, is because people are starting to speak the language of functional medicine once again. And really, it's common sense. So we're going to talk common sense language with hormones here today. So your patients that have hormone issues, and these are guys that we're starting out with first and foremost, so male patients, most of the time, they're going to be above 30 years old. Most of the time, they're going to have some level of metabolic dysfunction that is feeding or triggering an endocrine response. And that metabolic dysfunction gets treated as if it's different than endocrine dysfunction. And my job here today is to make sure that we unite both of those two problems together, because you cannot have metabolic dysfunction without having endocrine dysfunction. And I'm telling you right now, you cannot have endocrine dysfunction without having metabolic dysfunction. And so when somebody says your patient who's overweight, let's say he's a 40-year-old man named David, he wants to lose 45 pounds, and oh my goodness, the doctor told him, you don't have a disease, you just need to eat less and exercise more. That I want you to have a huge smile on your face when you hear a story like that, because what that means is the doctor that's treating them doesn't understand the connection between metabolic and endocrine function. So, with that in mind, we're going to go through this review here of male androgen pathway, specifically with testosterone, just to make sure that we know what we're talking about here. So let's get it out on the table. So the hypothalamus is talking to the anterior pituitary. Anterior pituitary is releasing LH, luteinizing hormone, which is talking to the Leydig cells. The Leydig cells are producing the testosterone. Now, when testosterone is produced, there's a negative feedback loop, which is like an off switch back to the pituitary and all the way back to the hypothalamus. So you get this double-layered negative feedback loop. This is really cool, and it's something that we can work with in the future here, so remember that. You should actually probably draw this out as we're talking about it. So hypothalamus on top, anterior pituitary releases LH to the Leydig cells producing testosterone, and then a double-layered feedback loop back to the hypothalamus and the anterior pituitary from the testes, okay? So now that we have testosterone being produced, what are the target tissues, right? Well, a lot of them, but we have maintenance of accessory reproductive organs. That's one of the issues that we find that testosterone helps satisfy. We also have secondary sex characteristics that are based off of the amount of testosterone that's present. Some of it can be like hair growth, right? Deepness of your voice. If you have somebody who has a high voice, even though they're a large man, versus a low voice like that, and you have this balance between the two, right? It's just things for you to think about as you're taking your history with this patient. Testosterone is also going to promote sex drive in most people, maybe some aggressiveness in the attitude. Protein synthesis and skeletal muscle. This is an awesome one to assess on your patients that have metabolic disease like diabetes. So you can look at their skeletal muscle. Don't be fooled by their forearms and hands, though, okay? So you get some guy that's been a mechanic his whole life and he has muscle wasting, except his forearms look like Popeye and his hands are humongous like a farmer, right? Like, don't be fooled by that. They can have awesome adaptation, but we're talking about like larger skeletal muscles. Look at their quads, hamstrings, their glutes. Do they have a flat butt, right? What do the skeletal muscles look like as they run up the spine? So some of the erector spinae muscles. So check out that type of stuff. Triceps are a good one, by the way. Triceps are a good one. If you have very tiny triceps, they're basically a good reflection for the rest of the physiology as far as muscle volume is concerned. We're also talking about testosterone driving up bone growth, and this happens typically in adolescence, but you can also look at that with adults as well if you're looking at things like osteoporosis, etc. So that is one hormone pathway when we talk about testosterone. What are we going to find in clinical practice with our patients that are dealing with testosterone-related issues? Well, low T. That's a rage right now. You have clinics set up in multiple cities where I live, at least, in the metropolitan area here in Minneapolis. You have testosterone clinics where they're on TV all the time advertising, do you have low T? I have low T. Bob, it looks like you have low T. Everybody has low T. Let's all get injections. And what's happening is they're not understanding the mechanism that's shutting off testosterone. Could it be protective? Right? Could it be protective? Like a lot of times people are having diabetic situations that have low T, and they go to their doctor and they're like, I just don't have any zip, doctor. I don't feel well. I don't have any get up and go like I used to. What do you think my problem is? And the doctor says, sounds like you need testosterone. You know, you lose 20% every decade after the age of 50. And you're like, that can't possibly be accurate, right? Otherwise you'd be at 0% within another decade. So anyway, the point is these are the statistics that you're going to see on TV. I just saw this the other day, and I was like, because I'm a little bit of a stats nerd, that's not possible. If everything's declining by 20% every every year after the age of 50, ultimately people are going to have no testosterone. You'd be negative testosterone at some point. So anyhow, when you look at advertisements like this, though, it's super enticing for a patient because they go, yeah, it's not my responsibility to figure out my health. Must be my low T. I'm going to go to the doc, get a little injection, some cream, see what happens. I'll be a raging 16-year-old again, and sex drive goes up, muscle mass goes up, and I'm going to look like that 75-year-old doctor that's on all the airline magazines when you take a flight. So anyway, the point is that's the patient mentality, is let's just see if I can fix this hormone because it's aging. It gets me, right? Like Father Time, what a jerk that guy is. And so your patients are having this put in front of them 57 times a day, sometimes passively, and it's not reality. Like, we got to ask the question, what if your testosterone's low for a reason? And if we look at what testosterone does, protein synthesis, skeletal muscle as an adult, sex drive, well, if I'm 60 or I'm 45, let's say, and I have diabetes and I want to lose 45 pounds, one of the things that needs to take place is we need to assess blood sugar control, liver clearance of hormones, number 2, and then number 3, what does the inflammatory level look like? What if testosterone's low because inflammation is so high? Like, if we increase your metabolism through hormonal pathways without allowing your liver to process inflammation at a faster rate, we get toxic pretty quick, right? We end up with muscle wasting because we're spending energy that we don't have. It's kind of like the last, I don't know if I did this on a podcast, but there was a seminar that I gave the other day about pain regulation and metabolism and how those two things go hand in hand. And what's really interesting to think about is testosterone and metabolism. You can increase your metabolism with testosterone, but at what cost? At what cost is the question. Is the rest of your body ready? Is it capable of supporting testosterone synthesis and then protein synthesis at an increased rate? Usually no. It's low for a reason. So we have to figure out those reasons. So I'm going to give you a hit list here. These are 3 things that you want to look at every single time somebody comes in and they're complaining of symptoms of low testosterone, or they got diagnosed with low testosterone and then now the doctor's giving them shots or into the buttocks, or they're giving, what's the other one I saw? Oh, this is a cool one. Doctor put a pill under the skin of one of my patients just above the hip, and that pill gets dissolved slowly over the course of 30 to 60 days. Are you kidding me right now? Like, what's happening when we do that is we're creating, and oftentimes this gentleman created testosterone resistance. And what does he need in order to feel normal when you have testosterone resistance? More testosterone. And this cycle just spins out of control. So these are the 3 things that we're going to look at on our hit list when we talk about testosterone regulation and assessment. Number 1, what's your metabolism, your A1C, your glucose metabolism? And if not your glucose metabolism, then maybe look at something like glycomark. What are your glycomark scores look like, and what does your A1C look like? If it's too low, you have no business driving up your testosterone. If it's too high, you have no business driving up your testosterone. So if we have a testosterone need, you have to fix the metabolism first. Otherwise, we're just going to double down on that metabolic problem in the long run. We're going to double down on it, right? We're going to reinforce it. So very, very important. That's number 1, metabolism. Number 2, liver function. Liver function. So if your transaminases, so we look at AST, ALT, GGT, you can look at bilirubin scores. We can also look at cholesterol and triglycerides, total serum protein, ELK, phos. If we look and assess the liver function and we decide that the liver is not properly functioning, we have no business driving up testosterone values. So we're going to create a toxic mess fairly quickly in that instance. Ask me how I know. So that would be the second thing. Number 3 here, and this is not something that you're going to find commonly in the medical literature, but this is just a clinical pearl from Dr. Brad Watts, and it's your immune system. If your immune system is jacked up, if your immune, too low, functioning too low, like white blood cells are suppressed, or we have neutrophil lymphocyte imbalances. Neutrophils and lymphocytes 2-to-1 ratio is what we're looking for if we're out of balance there. Or if we're looking at autoimmune conditions where we know we have a genetic predisposition for the immune system to be skewed in one direction or the other, like on a Th1, Th2 scale. If that's your patient, or if that's you have no business driving up testosterone values to make the patient feel better. We have to begin regulating the immune balance properly before we can expect their body to tolerate testosterone, number one, but then number two, before we can expect their body to produce testosterone again at a normal rate. So this is really interesting. So these are the 3 things, and the reason I think it's really interesting is because these 3 things are never assessed in a medical community. They're never assessed. What do we look at? Your testosterone score. What's your free fraction and what's your total, right? And if it's low, you have low T. Let's just load you up and see how you do. What's happening is that we are going to wreck the metabolic function even further. We're solidifying metabolic disease when you give people hormones for treatment. It's kind of like using insulin for treatment, right? It just makes the disease worse in the long run. So very similar with testosterone. You'll read papers right now on PubMed if you Google, if you just search on PubMed testosterone and diabetes. Yes, we're going to reverse the diabetic condition by giving them testosterone. Oh, by the way, they end up with cancer. Or, oh, by the way, now they have prostate cancer because we have so much aromatase activity taking place. And it's like, it's just madness. Madness. So if you're going to be a functional medicine provider, you want to make sure that you don't double down on the idiotic thinking that's out there in medicine right now. And I understand because it's easy for the patient and it makes cash, right? So that's what medicine's looking for right now. Does it work? Yes, in the short term. And is it profitable? Absolutely profitable, but not in a functional medicine space. So if you're one of those functional medicine providers, and I know they're out there, I've talked to a bunch of them. I was at a seminar in Miami, when was this? Earlier this year, and I talked to, it was a medical community, it was an anti-aging seminar, and talked to some gentlemen that they just don't understand. They're like selling hormones that are like growth factor. It's further up the hormone stream than human growth hormone, and which is illegal, by the way. But it's further up the stream, the hormone stream, the production stream, and they're selling it in kits that you take home and inject yourself with. What in the heck? They're talking about how to get rid of gynecomastia in a guy. And it's like, yeah, you got rid of his gynecomastia, but if you don't control his blood sugar, his metabolism, number 2, if he's not clearing it through proper liver function, and number 3, if he has an autoimmune condition that's unassessed, and the numbers on this, by the way, are crazy, the statistics on the autoimmune condition pathways, like 7 to 8 out of 10 people right now, they're basically predicting are going to have autoimmune diagnoses as the technology improves on our ability to assess this. If we're doing all of that, giving people these hormones without assessing these 3 mechanisms, yes, they're going to feel better, but for how long? How long before they just start ripping ACLs, all right? Their cartilage just starts falling apart. We look at the meniscus, their hips. Oh, all of a sudden everybody has shoulder injuries and it's unrelated. Oh, it's only orthopedic, as if that's a separate thing by itself. And so when we look at this, we want to make sure that you are first and foremost assessing your patient population with these 3 characteristics in mind. All right, that was a really long-winded way of saying let's just commit to it as functional medicine providers and assess the patients in a way that brings some logic back to the platform of healthcare. So when we look at low T, could it be that it's being shut down in the higher centers of the brain on purpose? Yes, that's one issue, okay? And we talked about those 3 pathways: metabolic, clearance, and immune. Could it also be that there's a problem with the negative feedback loop? Like, what if the brain is not receiving the information from the testes that there's a low amount of testosterone present? So we see LH then low in the presence of a low testosterone. When LH, luteinizing hormone, is low in the presence of a low testosterone, the negative feedback loop is oftentimes being inhibited by inflammation. This can also fit into those three categories that we looked at in the previous ones: metabolic, clearance, and immune. It can also be something as silly as just some level of excess inflammation in your patient base, like an infection. Something really silly like an infection is like a really easy on and off switch for testosterone production. So assess that type of a situation as well. So the negative feedback loop basically being blocked, or the pituitary not being able to read it appropriately. Okay, so we can assess all of these, by the way, with diagnostic testing right now. I would suggest doing it in saliva. You can also use blood testing for some of these hormones as well. But if you want to get an accurate overall picture, in my opinion, saliva is the best way to do that, because we're actually looking at target tissue content of these hormones. Saliva being coming out of the salivary glands, we're looking at the target tissue itself rather than what's floating around in the bloodstream. So the difference between the two in measuring, and I get this question often from providers around the country, is, what's the difference between saliva and blood testing? Because a patient came back and said that their primary care doctor, their endocrinologist, told them that, oh, we don't do that saliva testing because it's not accurate, right? And so what you would do in that instance is tell the patient, first of all, you would laugh and you'd say, oh, that is very, very funny, patient, because most of the time endocrinologists know this information. I'm surprised that they don't, right? So just plant it, move along. You don't need to make a big deal out of it. But the point is you want to make sure that you start to reel the patient back in by telling them something very simple. And the reason the doctor tells them that it's not accurate is because the doctor doesn't know how to explain it to the patient. So here's how you explain the difference, okay? Is you would say, patient, we want to look at the hormones coming out of the target tissue, not just what's in your bloodstream. If we just measure what's in your bloodstream, that would be like measuring the population of Chicago based off of who is on the highway right now, right? Like who's on 94 going through the city. If we did that, do you think we're going to miss people? Like maybe people that are in all the buildings downtown, people that are out in the suburbs? Yeah. Same thing with your hormones. If I only measure what's on the highway, what's in your bloodstream, we're missing the entire picture of what's already in your target tissues. And where do hormones actually have action? In the bloodstream? Not as much. In the target tissues? Absolutely. And so if you can explain it to them in a really simple picture like that and be like, so I want to know the full population of Chicago. I don't just want to know how many cabs are on the highway right now. Your patient will get it, and it gives you a leg up on the communication role here because it's easy, all right? So use that. I've used that one for 8 years. I did not invent that little description there. I took it from another doctor that was awesome and was way better at hormones than I was when I first started. So with that in mind, when we look at these things, we can measure LH content through saliva mechanisms and testosterone values. If they're both low, look for the negative feedback loop. If they're both low, it could also be that the pituitary is not getting stimulation from the hypothalamus, right? Using GNHR. If that's not happening, well, then we need to make sure that we look at the higher centers. And typically inflammation is going to be suppressing the neurologic function, which is contributing to the hypothalamus, telling the pituitary what to do. So if that is a mouthful and that doesn't make any sense, draw it out on your diagram. Okay, so hypothalamus, pituitary, Leydig cells. If the testosterone coming out of the Leydig cells is not feeding back to the hypothalamus and the pituitary, then it's a feedback loop issue, right? If the feedback loop is likely okay and you're still not seeing proper production, then the hypothalamus and the pituitary need to be organized. How do I tell the difference between that one, Dr. Brad? Here's how. We also look at FSH, follicle stimulating hormone. Follicle stimulating hormone coming out of the anterior pituitary as well is going to activate Sertoli cells for spermatogenesis. Sertoli cells releasing, basically, the sperm also has a negative feedback loop that goes up to the pituitary. So it's not a double layer like testosterone, it's a single layer up to the pituitary. And why? Because, this is just my opinion, but as people age, they still need testosterone, but you don't necessarily need to have sperm when you're 90, right? So anyway, we have this single layer negative feedback loop now up to the anterior pituitary, and that's going to either increase or decrease FSH secretion. So how do we assess feedback loop versus pituitary problem? If FSH is elevated and LH is low, with low testosterone, that's a feedback loop problem, right? So write that down. If FSH is low and LH is low, we may be looking at a pituitary issue. Okay, so if we're looking at this the right way, so there's two scenarios I just threw out there at you. FSH is high, meaning the anterior pituitary wants more sperm to be produced, and LH is low in the presence of a low testosterone. That means that the negative feedback loop on testosterone side of the diagram is low. Okay, the negative feedback loop is low functioning. That's important to recognize because that could be a metabolic, it could be a liver detox situation, or it could be an immune system problem. Very important. Now, if FSH and LH are both low, and we're looking at testosterone being low, then you may be looking at anterior pituitary suppression. Pituitary suppression. This is cool because this gives you a way to determine now, which way do I go, left or right with my patient? What do I focus on, right? So super cool because if you're going through, let's say you're taking on a patient and you put them through the metabolic clearing kits, you go through a deluxe kit and then a basic kit from biogenetics, and you retest and their hormone panel looks normal now, you are working on the negative feedback loops that are being suppressed by inflammation. Okay, so remember that. I'm going to say that one more time. If you have all these problems on their hormone profile and you go through a deluxe metabolic clearing kit and then a basic metabolic clearing kit and you rerun the panel and everything's normal, that means that the negative feedback loops were being suppressed by inflammation. Why? Because we worked on their metabolism, their liver clearance, and their immune system to chill out because you're getting rid of inflammation. Okay? Really cool. So with most patients that have hormone problems like this, that's where I start. I give them something like a metabolic clearing kit from biogenetics, and it's been produced in such a way to have the effect we're looking for. If you use diagnostics, let's say, to run a saliva panel on somebody, which I really appreciate the way they run their panels, or a Dutch test, which is a dried urine sample that measures very similarly. If we're doing that, the metabolic clearing kits have been designed with those tests in mind so that you can have an accurate representation, but not only that, an accurate assessment to be able to implement with your patient. So it's pretty sweet. So let's say, I'm going to throw out another scenario here for you. And I don't really want to make this too convoluted because if you're not taking notes, you're probably like, what in the heck is happening right now? But let's say FSH is elevated. What does that mean? Remember FSH hitting the Sertoli cells for spermatogenesis. It means that the guy's not producing as much sperm as he should be, or at least as much as the brain would like him to be, right? So FSH is elevated means we don't have enough sperm. FSH being low means we got a ton of sperm, or the negative feedback loop is being suppressed. So let's say you have somebody that maybe not a weight loss patient. Let's say they want to get pregnant, and male, female come in. They're trying to get pregnant, and they're like, oh, it's the lady, because everybody assumes it's the girl, right? and you assess this with the gentleman, his FSH values are elevated, and you go, well, that's not good. Your FSH is high. It means your brain wants you to produce more sperm. Well, if his brain wants you to produce more sperm, you got to ask, maybe you should go get a sperm count, number one. But then number two, what are we looking at for negative feedback loop function? And what are we looking at from pituitary signaling? Right? Is the pituitary even getting the signal from the hypothalamus in the first place? We can measure all this stuff. This is so cool. So you can dig in. If you just make the map of this, if you make the map on paper, or better yet, Google it, just type in male hormone pathway, and what'll happen is it'll give you the availability now to solve problems here, okay? If it's a negative feedback loop mechanism that is being suppressed or isn't functioning the right way, you always want to start by getting rid of inflammation, by supporting proper liver clearance, and by getting the metabolic situation under control. So the 3 triggers. Cool? If we're looking at more of a neurologic issue, this is where we come in with some of the other layers of supplementation to help in the long run. This is where resveratrol, turmeric, fish oil for sure, oh my goodness, and oftentimes glutathione are going to be helpful because they're able to work their way into the nervous system in a way. I shouldn't say into the nervous system, but you know what I mean. They're able to target nervous system function in a way that allows us to clear the fog. It allows the different structures of the endocrine system to communicate more appropriately along the way. So if you got 2 possibilities that you're dealing with your patient, what are you going to do? You're going to do both therapies at the same time, right? Both therapies at the same time. You're going to go through some level of metabolic clearing, and then you're going to dig in by organizing with resveratrol or turmeric or glutathione. And your patients are going to start to turn the corner, and you're going to see changes in them. How are you going to see the changes? You're going to measure. So one of the secret weapons for increasing testosterone, and I'm going to give away the goods here for you. It took me a long time to figure this out, right? So I'm going to give away the goods for you here, and you're going to have to make sure that you protect this information. I say it with a smile, but I am kind of serious, okay? Because I don't want you to slip into the mentality of, well, we'll just medicate and increase somebody's testosterone, okay? Don't slip into that mentality, first of all. But I'm going to give you the goods here, how to increase somebody's testosterone almost across the board. This is like the on switch for testosterone. Vitamin C and lipoic acid. Now, you don't want to do this, okay? You don't want to do this unless you're measuring. You don't want to do this unless you're willing to sit and serve your patient and continue to help them, right? Continue to help them promote better function overall, because otherwise you're just going to be like the medical doctor that's just going to give them testosterone. You might as well do that. It'd be cheaper in the long run, okay? But vitamin C and lipoic acid. Now, there's some research out there that talks about getting 2,000, 4,000, 8,000 milligrams of vitamin C in a day, which is a lot, by the way, and getting enough lipoic acid to match it, that you are driving testosterone production. How? Because in the Leydig cell itself, it responds to vitamin C and lipoic acid. The inflammation shuts down. The oxidative stress begins to chill out. That's how that works. It's like an on switch for testosterone. And it's a secret that I don't share with a lot of people because a lot of people are not disciplined enough in the functional medicine field. They just want the results. They look like the hero, and then the patient comes back 2 years later and they feel like trash because, yes, my testosterone went up and now I have testosterone resistance because we never fixed all the other stuff that was going on. Okay? So if you're going to do it with a patient, if you're going to do that, right, please make sure that you are willing to serve them from a complete functional medicine perspective, not just, hey, let's drive up your testosterone and you're going to be the testosterone hero, right? So make sure that we serve them completely, not just jack up their values. All right. Female hormones are going to have to come out on a different day here because I'm getting a little long-winded for you. But FSH hits the Sertoli cells for spermatogenesis. LH hits the Leydig cells for testosterone production. And we have these feedback loops that go back to the pituitary for both. And then testosterone also goes back to the hypothalamus. If you can understand that in a nutshell right there, you are going to solve a lot of problems. Okay? A lot of problems. But remember, always measure. And if you're going to supplement to drive up testosterone, better hit the 3 triggers first. Metabolic function, liver clearance, immune system. All right. You've been listening to the Nutrition Hero podcast. I am Dr. Brad Watts. I hope you got some value out of today's episode. Stay tuned. We are going to have female hormones coming up next, I believe. And might be a little bit longer of an episode because they can get a little fuzzy sometimes for clinicians. And so we're going to bring some light to those and put you in a position where you can be maybe the hormone hero. Maybe we should change the title of the podcast. All right. Anyway, enjoy the rest of your day, and we'll catch you next time.